All is well. Great. Welcome,
Yeah.
everybody. Welcome. Thank you for your patience. Actually, it is precisely 12:17, so let us begin, as we typically do at that exact time. Okay. So for today, good to see you guys. And if this is the first time that you're joining us, we're so glad that you're setting aside this time to participate in our Project Echo Dementia. And please do put your name in the chat. And we're fortunate to have Dr. Michael Persenaire speak to us today about rapidly progressive and treatable causes of dementia. And then we will have a case presentation with Patrice McNeil, DMP. We're all rather familiar with Zoom at this stage, but if you're with more than yourself, please enter the names of all attendees from your site onto the chat and mute yourself when you're not speaking and unmute when you're speaking, and turn your video on if you can, so we can, feel like we're in the same space together with one another and smiling and sharing. There's a number of UW programs, echoes, one in traumatic brain injury, behavioral health, which meets on the first and third Fridays of the month, sort of alternating with our second and fourth. There's a UW psychiatry and addiction echo on Thursdays. There's telebehavioral health training series on the third Friday. And there's also a really helpful telephone consultation for guidance for providers treating complex pain or chronic pain, particularly with high-dose opioids. You see the number here, as well as a UW telepain series that is also CME accredited on Wednesdays. So we never reveal any private health information, no PHI during any of the sessions, so don't display anything that could reveal any personal information for patients or family members. All of our sessions are recorded and available on the website, and please complete the 1-minute post survey so that we can continue to make this useful and helpful for you. If you're interested in having Dementia Friends rack cards, then enter your name in the chat and we can email them to you for your office. And lots of efforts are ongoing around destigmatizing dementia, and at the same time there's a lot of stereotypes and myths and ageism, and this is an effort to really build out collective support and dementia-friendly communities. So it's a great resource, and I encourage everybody to consider requesting these and maybe building out more dementia-friendly communities in your area. As you see, here are upcoming didactics. The next one is with Dr. Hilary Wang, who's going to talk about postoperative delirium, best practices for prevention and management. And we invite everybody here to consider bringing a case forward. It's really vital, so vital for the community. So the case presentations are really a rich opportunity to learn together. Email Allison or reach out to her. And there's CME accreditation for this UW Project Echo Dementia. We have no financial disclosures to report today. None of the planners, none of the speakers have any financial relationships to disclose. Here's our hub team. You all can wave, and then you can tell by the background of our video. And then we up to date have provided, wow, a lot of hours, a lot of instructional hours, 1,226 hours since starting in June 2020. And over 70% of survey respondents say that they would implement a practice change based on these learnings. So we want to continue to grow and build out this program throughout the state of Washington. So without further ado, let us welcome Dr. Michael Persenaire, who is a specialist both in multiple sclerosis and also in cognitive neurology. And he's here to speak to us today about rapidly progressive but treatable causes of dementia. Thank you so much, Mike, and take it away.
Thanks, Nancy. And you folks are not seeing presenter view, correct?
Correct.
All right.
Well, I mean, I think, yeah, we're seeing your slides, but not, I believe that we are just seeing your slides.
Okay, very good. So I'm going to talk about, I'm actually going to give a framework for approaching a case of a rapidly progressive dementia, focusing on identifying treatable causes. To go into any detail on any of the one of maybe, 50, 60 causes would not be possible in 20 minutes. I'll talk a little bit more in detail about autoimmune encephalitis at the very end. But first of all, beginning with definitions. The definition of rapidly progressive that is most commonly used for research and in writing about these topics is that an individual has gone from the interval from the time when they are first symptomatic to the point in time when they reach a severity that would meet the criteria for dementia or major neurocognitive disorder has to be within 1 or 2 years. But in reality, the cases which are rapidly progressive and more likely to be treatable are going to be pretty fast in progression. It's going to be more like days, weeks to a couple of months. When you do have cases that are progressive over hours to days, this time course suggests a greater probability of something like an infection or a vascular cause, whereas day to weeks more likely to be immune-mediated, toxic or metabolic. Months to years is still actually more likely to be a neurodegenerative cause rather than a treatable cause of rapidly progressive dementia. And by treatable, I don't necessarily mean curable. In some cases, a cure could be expected and very good outcomes, NMDA receptor encephalitis, for instance. Whereas I'm also including diseases that would have some kind of disease-modifying therapy or treatment that can maybe halt progression or significantly slow progression. Think, for instance, a shunt for normal pressure hydrocephalus or acyclovir for a viral meningitis like HSV meningitis. The likelihood or the incidence of these in the clinic is estimated to be around just 3 to 4% of cases. So it's going to be pretty rare in most of our experiences. A lot of people who are progressing from normal to severe disabling cognitive impairment, over days and weeks would be admitted to a hospital. So if you're an outpatient clinician primarily, you're not seeing a lot of those cases. They're being evaluated in the hospital. They may be following up with you later on. I want to talk about 3 different clinical pathological case cohort studies that teach us what the causes of rapidly progressive dementia are. The first comes from the National Prion Disease Pathology Surveillance Center in Case Western. This is a cohort of individuals who have been referred to this center because the clinicians doing the evaluation suspected that they would have Creutzfeldt-Jakob or related prion disease. And many of them, in fact, do. But about a third of the cases that they had seen from 2006 to 2009 did not. And they do autopsies on many of these cases. And this report is a report on 304 of these cases which had not been, where a rapidly progressive dementia had not been due to a prion disease. And what they had found was that the actual pathologic diagnosis fell into the category of what would be considered a treatable or at least potentially treatable disease. This is the breakup of the cases that were seen at autopsy. You see that still many of them were some form of a neurodegenerative disease. But something like 8% fell into the category of a toxic metabolic problem, an immune-mediated disease, neoplasm, some of which will be more or less treatable, and infectious disease. This next pie chart is a German cohort. These referrals to this tertiary referral center in Germany was not meant to was not meant to do evaluations for cases thought to be prion disease, but was just a more general memory disorders clinic doing evaluations for any cause of rapidly progressive dementia. And when you look at a cohort like that, you actually find that when you take out prion diseases, that's all three of these case cohorts are going to show you what the non-prion causes are. You see a higher prevalence of treatable conditions here, maybe up to 21%. And then in the University of California, San Francisco cohort, almost half of the non-prion diagnoses would have been considered treatable. So, although it's still going to be somewhat rare for any of us to be seeing these in the clinic, when you do identify a case, there is a fairly decent chance that you're dealing with a treatable disease, and therefore it is necessary to do the proper evaluation and take care of that evaluation very quickly. The sooner people get treated for these, in general, the better they'll do long term. This is an incomplete differential diagnosis. I do still rely on this vitamins mnemonic to generate differential for these cases. I don't have this memorized. If I see a case of rapidly progressive dementia, I'll still pull this out either through a review article or something like that. And I will look at all of these things, and then as I'm taking the history or maybe going back and thinking about the case, I'm asking questions and reviewing the MRI with these specific diseases in mind. Some of them could be something that a non-specialist would be able to identify. Many of these are going to be things which would require a specialist to identify. I think it's also useful to just have in mind a set of red flags that indicate that you're dealing with a potentially treatable cause of dementia. The number one red flag would be that it is a rapidly progressive case. Again, especially if you're seeing the progression over days to weeks. Also, there's higher probability of dealing with a treatable cause when you're seeing a case of dementia in somebody younger than typically have dementia. When you see prominent fluctuations in symptoms, that can certainly be seen in some of the neurodegenerative causes like Lewy body, but can also be seen in people who are having seizures or autoimmune encephalitis, in which seizures are relatively common. People have a high exposures to risk factors for treatable causes, either because they have a compromised immune system, or because they are engaging some kind of risky sexual or substance use behavior. If people have unexplained or unanticipated findings on the neurologic exam, and a lot of these come in the form of motor abnormalities, but abnormalities of the extraocular movements, people presenting with tremors or tone abnormalities that can be spasticity or rigidity, or if they have focal or motor or sensory deficits. That does not mean that the cause is treatable. It just, if you're seeing those, that does increase the probability that you're dealing with a treatable cause. And then identifying individuals that have systemic symptoms like fever, fatigue, rash, cachexia, night sweats, headache, or myalgias. The diagnostic evaluation for rapidly progressive dementia starts with a detailed history. You should always be taking this history from the patient and a knowledgeable informant, including calling, family members on the phone if you need to in order to get that additional background information. But one of the most important things to do initially is actually confirm that the case is rapidly progressive. The most common cause of rapidly progressive dementia is that the history is indicating a rapidly progressive dementia, but that's because the history is inaccurate. People are dismissing early symptoms or some kind of symptom that is fairly dramatic, like a seizure comes along, or language starts to become impaired, or somebody just makes a really dramatically poor decision, and that sticks out in the patient's or the informant's mind as the onset of the disease, where if you go back more carefully, you'll find that they had been making, there have been subtle changes, making some errors over the course of years, and then you're more likely dealing with a neurodegenerative disease in that case. You also, you certainly could have a case where somebody has a neurodegenerative disease, say mild cognitive impairment due to a synucleinopathy like Lewy body, and then somebody gets put on an anticholinergic medication, and then there's a dramatic decline in their cognitive abilities. So that's maybe not a treatable cause of every aspect of their cognitive impairment, but you still identified a treatable component of their current syndrome. And then it's also very important that you take a thorough history of which medications, supplements, and any other kinds of substances that people are using. On the physical examination, you want to make note of some non-neurologic signs. Is the person cachectic, indicating that they could have poor nutritional status, higher likelihood that they would have something like a thiamine or other vitamin deficiency, whether or not they have the signs of liver disease, indicating that they could have a change in the metabolism of medications, so functionally altering the dose, even though they're taking the same dose of a medication, which can cause cognitive impairment, or could be due to something like hepatic encephalopathy itself. And also looking for signs of other kinds of diseases like severe hypothyroidism, causing the skin changes called myxedema. On the motor exam, examining also for some of those red flags like extraocular movement abnormalities, looking for both upper and lower motor neuron signs, evaluating the extrapyramidal motor function, looking for signs of Parkinsonism or ataxia, and then also looking for focal motor weakness. Many of the potentially reversible causes are not global brain changes, but focal brain changes, and those are more likely to cause a focal motor deficit. Allison or Nancy, if somebody puts a question in the chat, will you just call my attention to it? I'm not able to see them.
Will do.
Okay, so when you think you have identified a case of rapidly progressive dementia, whether or not you think it's likely to be treatable or not, I advise, many people advise doing a tiered approach to testing, and there is not a one-size-fits-all to this diagnostic evaluation, but almost every single case is going to require the following first tiered testing. A brain MRI with and without contrast, very important that it be done with and without. Many of the cases like infection or cancer or the inflammatory diseases are much more likely to be picked up if you include post-contrast imaging. If a CT can't be done for some reason because of an incompatible implanted device like a pacemaker or defibrillator, or the person is just behaviorally unable to lay still for an MRI, a CT scan is a distant second best imaging modality. So always try for MRI if you can. There's a few routine lab tests that should be done in every case: complete blood counts, comprehensive metabolic panel, making sure that you're reviewing magnesium and phosphorus in addition to the other electrolytes, checking the B12, folate, TSH, HIV. When people are on medications that we know can cause cognitive impairment, like anti-seizure medications, AEDs, or something like lithium, checking levels of those medications is a good idea. Checking a urine toxicology or urinary analysis. It's probably not best practice to just check a UA in every single case, but screening for symptoms of urinary tract infections and testing when you think there are even subtle signs of something like that going on. If an EEG is actually a relatively low yield test, but it's safe and an important adjunct to the treating to the diagnostic evaluation. If you think a non-convulsive status or frequent non-convulsive seizure are even a remote possibility. So people that are having things like unexplained speech or behavior arrest, unexplained falls, movements in the middle of the night, just seem to be zoning out or having a lot of fluctuations. Just a routine EEG, again, even if the person is having seizures, a routine outpatient EEG is unlikely to actually pick that up, but once in a while you do get lucky. And there are some other fairly specific EEG findings that can clue you into the possibility of a more systemic metabolic disease, or some specific features associated with various forms of autoimmune encephalitis, like NMDA receptor encephalitis. You may not proceed directly to cerebral spinal fluid testing in most cases. If somebody is progressing over the course of days and hours, you're basically doing the cerebral spinal fluid, as soon as it can be done, even before imaging. But if things have progressed more slowly than that, and the cause of the person's symptoms is not already clear based on the initial testing, cerebral spinal fluid testing is a must. And the test to send initially, there's a tiered approach to CSF testing as well. The test to send initially are going to be a cell count with differential protein glucose. And then, excuse me, I recommend always sending the following tests, because you can't send them later on. You'd actually have to repeat a lumbar puncture in order to send oligoclonal bands IgG index, unless they're sent at the time the cerebral spinal fluid is obtained. So those can't be added on. So now when you do get CSF, make sure you're looking for oligoclonal banding and IgG index. Those are not just tests for multiple sclerosis. Those are tests for the abnormal activation of the humoral arm of the immune system behind the blood-brain barrier, which can be seen in many causes of immune-mediated encephalitis. And then also sending for cytology and flow cytometry. The 1433 tau RT quick is a set of 3 tests, which are always done if you send the CSF to the National Prion Disease Laboratory. That is something which can be added on later, so it doesn't necessarily need to be sent immediately. But if you do, and that's the 1433 and tau, those are just non-specific biomarkers of neuronal injury. So they're not specific for anything. If you do see very low levels of tau, you're probably actually not dealing with a progressive or rapidly progressive case. So in virtually all cases of a rapidly progressive cause of brain damage, the tau levels will be very high. So that's somewhat useful. The RT Quick exam is a test specifically for prion diseases. If you do decide to send that, you should call the lab ahead of time and let them know that you're testing cerebral spinal fluid for these measures, and they will handle the cerebral spinal fluid a little bit differently, even though the probability of somebody getting a prion disease from handling CSF is extraordinarily low. It can contaminate equipment, so they have to do things differently in the lab. And then the second tier testing is going to be based on the results of the first. A couple of diagnostic evaluation pearls to be aware of is that all of these tests are very important, but none of them rule out a treatable cause. So if a brain MRI is completely normal, that does not mean that the case is untreatable in any sense, so that you've ruled out all treatable causes. Same is true of cerebral spinal fluid and EEG. And then I'm going to say this once again later on. If you do antibody testing, you really should be doing that on blood and cerebral spinal fluid. The best antibody tests right now are done at the Mayo Clinic. The commercial labs don't do quite as good of a job. They don't confirm the presence of these antibodies on actual tissue in many cases, and they're not always doing cell-based assays. So when possible, I recommend If you're going to look for antibodies, going through the Mayo Clinic if your hospital will allow that. You need to send them on both serum and cerebrospinal fluid because many of the autoimmune encephalitides, the antibodies are being produced in the periphery. They wouldn't be found in the CSF in detectable concentrations. But then there are others which are really being produced in the cerebrospinal fluid, and you wouldn't detect them if you only sent blood. And then also remember to take a good cancer history, asking about smoking history or B symptoms, and also finding out whether or not somebody has a diagnosed or even undiagnosed additional autoimmune disease. People that have one autoimmune disease are at a high likelihood of developing or having a second autoimmune disease because all of these, many of these things share some genetic risk factors and are fundamentally immune system dysregulations. And then finally, I'm going to talk about this one specific cause of a treatable but rapidly progressive dementia, and that is autoimmune encephalitis. When people think about rapidly progressive and treatable diseases, this is the one that comes up very frequently, and many people are misdiagnosed with this because I think it seems to me that people are basically diagnosing autoimmune encephalitis when there doesn't seem to be an alternative explanation. But that's not really the appropriate diagnosis of autoimmune encephalitis. This should be something which is ruled in. And if you've never seen these diagnostic criteria, this paper published by Francis Grouse in 2016. This is a worthwhile paper to have in your virtual library, and you can review this diagnostic information, this diagnostic criteria. But this is the most general category of an autoimmune encephalitis. There are criteria for specific forms of autoimmune encephalitis like Hashimoto's or NMDA or Bickerstaff's. But this is the criteria for a possible autoimmune encephalitis. And so a person must have a rapid progression of cognitive or psychiatric symptoms, and then at least one of the following on exam: focal CNS findings, seizures when they hadn't had seizures before, inflammation in cerebrospinal fluid. They include elevated white blood cell counts. The current diagnostic criteria don't include oligoclonal banding or IgG index, although I do think that those measures are indicating something very similar to what a white blood cell count is telling you. And then, or they should have MRI features suggestive of encephalitis. That's what these panels are showing. Most of these are FLAIR images showing T2 FLAIR hyperintensities, either in the medial temporal lobes. These are part of the limbic structures in limbic encephalitis. Or in the white matter, even gray matter, that could be acute demyelinating encephalomyelitis, ADEM. That could be ADEM as well. And then just contrasting with that with the T2 FLAIR hyperintensities that are most consistent with multiple sclerosis. And then in the bottom right corner, I want to point out an MRI showing cortical ribbing. Cortical ribbing is a buzzword that in most people's minds means prion disease. But cortical ribbing is not specific for prion disease. It can be seen in prion disease, but it can be seen in other, including treatable causes of encephalitis. So here is a DWI image. You see that the cortex is abnormally white. If you looked at the ABC images, you'd probably see some darkness indicating there's restricted diffusion in these areas. Some of the other causes of this could be seizures, unlikely to be a multifocal seizure causing this, but possible. Stroke can even do this, but some forms of autoimmune encephalitis can do this as well. So finally, I want to just summarize and provide some recommendations. Keep in mind that a rapidly progressive dementia is just a small fraction. You rarely come across these cases, but when you do see them, it's a substantial minority that can be intervened on. So it really does require that you organize the diagnostic evaluation urgently. be able to recognize red flags for potentially treatable forms. Good idea to keep a review article or a couple review articles on hand. Read those when you are coming across these rare cases. The author that I like best is Mike Geschwind, and he has several iterations of his review articles, so just get the latest one. The history is by far and away the most important diagnostic test in any of this. So quite often I'll take a history, I'll remember to, as many of the things on the differential as I can. I'll go through whatever images diagnostic testing I have available. If I'm not already sending this person to the hospital, I'll often call the family back or call the person back or have them come back and take some additional history to make sure I've covered all the questions that I wanted to get done. And then I think we should be using tiered approaches to diagnostic testing rather than just sending every blood and imaging test that you can possibly think of. That requires a lot of that uncovers a lot of false positives and red herrings, which create a lot of confusion. And then this is not a thing which should be done. You should be attempting to do in the clinic in many cases, because it's so important to diagnose and treat the earliest possible moment. If somebody is experiencing this progression over the course of hours, days, weeks, I think it is a good idea to have them admitted to a hospital for an expedited evaluation. And with that, I'll conclude. I'm happy to take any questions.
Thank you so much for that great presentation. And while these are rare, as you say, I mean, we have to look really carefully, and particularly for the history, and don't want to miss these cases. So yeah, I'm curious if anybody has any questions for Dr. Persenaire. You could stop sharing your screen and we can see. Yeah, Sylvia, Dr. Russo.
Hi, thank you for this overview. It's always very helpful. It may not be the specific topic of, in general, the discussion, but it's kind of a subcategory of this. In terms of autoimmune encephalitis, when you are in the community and, there's not a whole lot of neuroimmunologists willing to take on these cases, once you've made the diagnosis and, you've confirmed it, and talking specifically about LGI-1, autoimmune encephalitis, that comes with its own set of symptoms. How do you assess for response, and how do you assess for is it actually improving when the person may still have dystonic attacks, but their memory may be getting better? Is there any kind of quick tips or pearls, of course, other than getting more subspecialized advice in those cases?
You'd have to go based on what the person's symptoms are like. You pointed out correctly that a person with that specific form of encephalitis can go on to have seizures, or the kind of characteristic dystonic seizures, the facial-brachial dystonic seizure, and certainly can have chronic amnesia, chronic memory loss as a result of the destruction done by the encephalitis. But you would want to treat to improvement, or at least stabilization of the symptoms, so the person shouldn't be continuing to get worse. And in that specific disease entity, you will see in most cases a quite dramatic improvement in the symptoms. So for some of these diseases, you have to kind of know what to expect with treatment. It's not the case with every single one of these treatable diseases that you're going to actually see an improvement. But that one you would expect to see an improvement. And then in some cases, you can also use MRI and cerebral spinal fluid. You would also want to treat to the point where you're not seeing still pleocytosis or enhancement on an MRI. But even for the cell surface antibodies like LGI-1 or NMDA or NMO, where the antibody is thought to be pathogenic, still in those cases, measuring antibody levels does not seem to be that helpful. So it's really the clinical symptoms, making sure that you've got stability, no longer getting worse. Some of the MRI findings, in some cases, rechecking CSF to make sure that there's no evidence of inflammation ongoing.
That makes sense. Thank you so much.
We have a couple more minutes for any questions. Karen, do you want to unmute yourself, or would you like me to? I can read it if.
Oh, I can see it there, Nancy.
Yeah.
How does pre-existing known dementia affect the approach to the evaluation and interpretation of rapidly progressive dementia? And is the approach different depending on if they are early, mid, or late in their neurodegenerative dementia journey? The last part of that question, I think, is relevant. It depends on a person's goals of cares. If somebody is in the late stages of dementia, you are maybe not wanting to admit somebody to a hospital for a bunch of invasive tests if that's not aligned with their goals. But the other aspect of that question, how does dementia affect the evaluation? I don't think just having a neurodegenerative disease really would affect the evaluation. You're probably somewhat less likely dealing with a second disease altogether. You're probably somewhat more likely dealing with like a medication side effect or an infection or something like that in that case. But there's nothing about having a neurodegenerative disease that protects you from developing cerebral amyloid angiopathy related inflammation or an autoimmune encephalitis or a treatable brain cancer. So I think the diagnostic evaluation pathway is still going to be pretty much the same.
We have time for maybe one more question, and then we'll shift gears and have our case presentation.
This is Karen. I'll just ask one more question. If you're a primary care provider, especially if you're rural or so forth, who would you recommend people get referred to get this workup?
If you have a neurologist that is in neuroimmunology, usually going to be thought of as a multiple sclerosis specialist, that would be one person to go to. And it's not that a multiple sclerosis specialist or neuroimmunologist has relevant expertise to all of the things that could be going on, but those people are so often put in the position of having to do these evaluations that they generally know of the autoimmune causes of this and can handle that evaluation or know when to refer. But if you don't have access to that kind of specialist, a general neurologist or a psychiatrist is the next kind of specialist to go to. But these evaluations are actually tricky. I think getting the first tier testing and taking the good history, that's what would be expected of a non-specialist. But beyond that, I do think it's going to require specialists. These cases come into the hospital, even hospitals not associated with the University of Washington. Those providers are calling us quite frequently. We have our own ECHO project in neuroimmunology where people can come and present cases and things like that. But
Great. Super helpful. Thank you again. Before we move to the case, please, if you're new, put in the chat your full name, your clinic name, and an email. So Allison can knows where you're from, and so she can reach out to you. Thank you. Okay, great. And now we're very fortunate to have Patrice McNeil, who is from Ripple. She's a nurse practitioner there, and she's going to share a case for us today.
Hello, can you guys hear me?
Yeah, we hear you very well. Thank you.
Thank you. I'm actually speaking from my phone because I've been having technical glitches, so please bear with me. I'd like to present a patient that I saw. She was my very first patient here at Ripple, 65-year-old female. She was diagnosed with FTD in 2022. She currently resides in a locked memory care. She had a MRI of the brain originally in 2022 that showed that she had some regression of the brain. And then she had a repeat scan in 2023 that showed no changes. Currently, her primary medical history includes FTD with episodes of hypotension, hypercholesterolemia, hypothyroidism, osteopenia, and mitral valve prolapse. This is very interesting. Her family history is extensive. Her grandmother and brother both have Alzheimer's. Her sister has dementia. Didn't state what kind. Her mom has vascular dementia, and she has a son who has bipolar schizophrenia. Her husband, her doting husband, said that she started having problems in 2013. She had taken a new job and was unable to learn the new skills at the new job, which he thought was very surprising because his wife had worked for a surgeon for many, many years. And that's when he noticed that something was not right. And since then, she had steadily begun to decline. Currently at the memory center that she's located, very concerned about, she had new symptoms of increased agitation, and being angry after family visits. She was seeing visions of family members that were deceased and a dog that she loved, a black lab who had died about 6 months earlier. And she's been very anxious and she was very paranoid, thinking that the staff wanted to harm her, thinking that the staff wanted to steal her husband. He had never seen her in that way before, and the primary care had her on myriad of medications, but it just didn't seem like it was working for her. She has some traumas in her life, which I think are important to bring to the forefront. I did mention prior that her son has a history of bipolar schizophrenia. He shot a pastor because he saw aliens. He's currently, unfortunately, incarcerated. She was a victim of sexual assault as a teenager, and her assailant resembles her husband. So sometimes she would become agitated with seeing him. She had C. diff in 2015, where she likely died from, and her favorite dog died 6 months prior. She loves food, family, church, kids, grandkids, camping, skiing, and weeding. Actually, she loves to garden. She doesn't like traveling abroad, and she doesn't like cruising. Also to mention that her husband also stated that she dislikes medicine. She dislikes clinicians. She hated going to the doctor. She never kept up with any of her visits. In September, October 2022, she started becoming very agitated, didn't know where she was or, who he was. Prior to that, she was being managed well with Seroquel, 25 milligrams 4 times a day. And he said that she was doing well. And then she just stopped taking all of her medication. She refused. She would say, "This is my body. You don't tell me what to do, and I don't have to take it." And then in December, she had another episode where she did not know her husband, did not know where she was, and did not recognize her own home. in the facility, they noticed that she was always saying she has to leave. And with speaking to her husband, he stated that that was something that was a part of their normal conversations at home, even prior to her having issues because of her strong family history of Alzheimer's. And she would visit her mom and her siblings in care units, and she just said she never wanted to do that if that happened to her. She was becoming more weepy with family visits greater than 30 minutes. She always wanted to leave with her husband, and she'd become very agitated when he was leaving. She's mothering to other residents, and she's able to perform all of her ADLs without assistance. She's fully functioning. She also speaks in 2 to 3 word sentences, and she has some cognition, but it comes and goes. It's infrequent. So the concerns were in the care community that the weather is changing. She likes to garden. They want to allow her to go into the locked garden to plant flowers because that's something that she loves. She's been refusing medications consistently. As I said before, she said, "This is my body, I don't have to take it." Her husband felt like her behaviors were more stable when she was on the racemine patch. She was on that prior to her going to the ER in December. He felt like she was more compliant and stable. And she was more compliant also with taking her medications in the morning instead of taking them in the afternoon. In April of 23, she was just refusing all meds. In that month, there was probably 3 days where she took her medication after we totaled it out and went through all her lists. She was still having paranoid behaviors, thinking that the staff was trying to hurt her. She was becoming aggravated with other residents. She was intimidating other residents and mothering other residents. She was a perpetrator to one of the other residents. He pushed a resident back into his chair because she felt like she wanted to protect him so he wouldn't fall. She was also intimidating another resident along with another resident. And she hit another resident for being too loud. She had 3 hospitalizations in the last 6 months for behavior incontinence and hypotension. She did have labs done, CBC, did CMP lipids, and thyroid. EKG in January at the hospital was normal. The labs were normal except that her lipids were slightly elevated and her protein was slightly elevated. At that time of the initial visit, she was taking quetiapine, 50 milligrams in the AM, and she was taking 25 milligrams in the PM. She was taking olanzapine, 5 milligrams as needed. She was taking Depakote, 125 milligrams twice a day, melatonin at night, and midodrine, 5 milligrams if her blood pressure dropped, her systolic blood pressure dropped less than 100. And the non-compliance, the Seroquel, 50 milligrams in the AM, 25 in the PM, which was prescribed for agitation and anxiety. She refused it 7 times in the month of January, 4 times in the month of February, and 3 times in the month of March. And so the plan was to stop the olanzapine oral, stop the Depakote and the Seroquel, start Zydis 5 milligrams ODT, and follow up in 1 week and create a safety plan. And my questions were at the time was, how do I promote compliance with medication in a locked memory ward? How will I know when it is unsafe for her to be there? If failure to thrive becomes an issue, what are the next steps? And she was having issues with failure to thrive. She stopped eating and taking all of her medications for about 7 days. How do you feel about IM Haldol in this situation? And what other non-pharmacological therapies can be initiated?
Okay, I'm going to leave these up here for a bit for us to sort of reflect on them, and then also to see Are there any questions for Patrice? Thank you.
Oh, yes. Any questions?
I would ask, if possible, one question about the case is, how did the diagnosis of frontotemporal dementia came to be? Because it's a quite big distinction in treatments if it is frontotemporal dementia versus, early onset Alzheimer's disease. And those are really hard to distinguish. They can look really the same if the person is young. And by young, I mean 65 or younger, when they started having the symptoms. And the thing that cued me off is that she likes to mother people. And that's a kind thing, which typically frontotemporal dementia doesn't leave intact, that mothering reflex. Typically, and again, we're talking typical issues, the frontotemporal dementia patient becomes indifferent, lacks empathy, because those circuits are affected. And so I wonder where the diagnosis came from, and that can kind of determine whether the treatments are right.
Thank you for your question. So with seeing this patient, the information that I received was from the primary care doctor itself. And the information that I received didn't have copies of the imaging that was done, but she was diagnosed, I believe, at the hospital in 2022. And so I think your question is a great one, because is she diagnosed correctly with that empathy, like her being able to mother other residents? That's interesting. But the only information I had was face sheet from the LOX memory care unit and one office visit note from the primary care, and still waiting on other medical records to come in. So would your suggestion be, tell me what your suggestions are. That's interesting.
Yeah, so I see a lot of these coming in with that suggestion of frontotemporal dementia. And the usual thing is trying to reconstruct the history with the caregiver and trying to see what's the first symptom that happened, not the first symptom that you remember, but really going back with the knowledge and hindsight, what happened first, and then kind of going through the clinical criteria. And probably this needs a neurologist if she hasn't seen one, and not to discredit people in the hospital, because they do a valuable, indispensable job. But maybe when you're in the hospital, you don't have time to spend an hour asking these questions. So really a clinic visit with a neurologist should be where the starting point is. And I know she cannot go anywhere right now, so even just video visit, just to understand how the symptoms develop, and does she meet criteria for frontotemporal dementia? And one of the exclusionary criteria would be, was memory and visuospatial function affected in the first 3 years of disease? And again, this is extremely hard right now because she seems very advanced, but if those were affected, those are exclusionary criteria for frontotemporal dementia. And typically the way that this is, that this develops is the person becomes cold, distant, and detached. And their memory is great. They remember everything. But somebody in the family dies, and they don't care. Or their spouse gets a heart attack, and they look at them clutching their chest, and they're just eating popcorn. It's very dramatic. And there is variance of it, of course, but reconstructing how the symptoms began, it's really important. And that kind of helps us understand, where do we go from here, and are the treatments appropriate? And I think we had a case similarly before, where even last week, I think, or 2 weeks ago, where really psychiatry or geriatric psychiatry needs to get involved, just because of the amount, the doses, and the types of medications that are being used. These are psych medications.
Thank you.
Thank you, Sylvia. Dana Long, you have your hand up?
Hi, Patrice, I'm just wondering, do you know if that patient had any history of any psychiatric illnesses at all prior to being diagnosed with FTD?
Well, I know her husband said that she had issues with anxiety, but she was prescribed medications in the past. She never took them.
Okay, thank you.
I must add that I know she is kind of reclusive where she is. She sticks to herself. She doesn't like to involve herself in a lot of different things. But she does. The mothering part is a very interesting aspect.
Anybody else with some questions? For Patrice?
Dana,
I
do
mean,
you
some
have
of the,
a question?
pardon me.
I see Dana's hand is still up. Just
Oh,
make
yeah, I saw that it was still, yeah. I think yeah, I mean, it's interesting to think about the mothering in quotation marks behavior too, because while a maternal, kind and gentle, affectionate behavior wouldn't be typical, if somebody has a disregard of relationships and is sort of intruding in the way that you kind of described, the getting in between people and speaking out, and it's hard the disregard of social mores and inappropriate behaviors and sort of disinhibition might be something that you could see, is more typical of FTD. I agree that it can be very hard to differentiate, and you want to get a very careful history with the, parallel historian early on. It's just hard to know what that was. Is it tending, or is it sort of I'm wondering too, Trang, if you want to comment on her medications.
Yeah, I have a question for Patrice. Do you know if she has issue with insomnia?
She was having some issues, but since she's been taking the Zydus ODT, she's been sleeping throughout the night. So right now she hasn't been having any issues.
So she is taking Zydus. She's not refusing it? Okay. Okay.
No, she's actually since stopped the polypharmacy, and she's on Zydus ODT, and her husband, there was a period of time where we thought they were gonna have to send her to hospice because she refused to eat and take any medications, and she was losing weight. And so her husband decided to come in every day to give her medications, to bathe her, and to assist her because she was refusing anything from the staff. And so once she started becoming more compliant, she's been improving. Actually, I actually just had a follow-up yesterday, and she's just doing so much better.
Oh, okay. So she knows that she's taking the medication.
Yep, she's taking the medications. She's taking it now from staff. Before it was just him, and once she started to become more compliant, she has been more congenial with the staff and interacting with the staff and allowing them to assist her.
Oh, okay. Well, that's good. I thought maybe she's still refusing, and we can get medication that can be crushed, and ODT can be crushed. So you hide it in food, choose medication that is once daily, and then it can be crushed, and then the patient can take it that way. But if you feel it's helping her and she knows that she's taking her medication, and then there's no, I think that's good. I thought if it's not helping, and I was going to ask if she already tried an SSRI previously.
I didn't, if she tried what? I'm sorry.
An SSRI, like citalopram?
Her husband said they prescribed something before. She took it for a few days and she stopped taking it. But currently she's not on one.
Okay. Okay.
And Karen.
Yeah, hi. I had a question about the husband. Sounds like he's primary caregiver. And do you know if he's getting support? Does the facility have a caregiver support group? Or it sounds like there's some family members who might not be able to step up for him because of their own medical and psychiatric issues.
Yes, actually, when at Ripple, we have a model where we help to treat the caregivers as well. And I've offered him support with our social worker. We have services that can assist him. He says consistently that he's fine. He has a strong support system.
Good.
And spoke to him last week and he said he's just doing so much better because because the patient is doing better.
Yeah.
So he's thrilled, and he knows, because every time I talk to him, I say, do you need us? You need anything? We're here to help you. He says that he's well. Yeah.
Great.
It was.
Thank you, Karen. That's such an important component of the care, and it's wonderful that he's feeling better and you've been checking in. Kimmy, I wonder if you have any thoughts you'd like to share.
I guess one thing that often is in the back of the minds of families, and maybe was asked before, is you talked so much about the family history, and I don't know if they have wondered about, is this something that runs in our family? Is there a gene that should be tested for? And the opportunity is, really while the person is alive, and now that she seems to be settling in more, I just don't know if it might be worth talking with them about options if that's something they want, because sometimes families, they think, and then the person dies, and the question remains. And at the moment, it may or may not change care. It may also help, Dr. Russo's question of, wow, could this be early onset Alzheimer's? I don't know if that's been talked about, or I don't know if you came across that on the records.
I didn't come across it on the records, but I will bring that up because they do have a daughter, and she has two children, and I think that's prudent to bring that up. So that they could be proactive with their health and their care. That's a good call out. Thank you so much.
Sure, and we've mentioned it in the past that even if people are not prepared to learn the results of the tests, there are options to like bank a sample, and if and when someone in the family feels prepared to learn it, then they can. But again, it's collecting the sample while the person's alive.
Thank you. Thank you.
Thank you, Kimmy. And Karen Clay, I wonder if there's any comments you'd like to share.
Sure. Yeah, a couple, actually. I'm a social worker by training. I work at the Memory and Brain Wellness Center. I guess, one of the questions that you posed was sort of like, is this facility going to be able to meet her care needs over time? And I think that one of the things that's really tricky for folks that have FTD-like behaviors is that there isn't a facility that really specializes in that type of care anywhere in Washington that I have been aware of. But a lot of the facilities have done their best to sort of increase their knowledge and care specifically to those types of FTD type of behaviors. And, there are whole lot of resources on the Association for FTD website. They have a publication called Partners in Care that's actually geared towards care facilities and increasing their skill and knowledge and supporting people around these behaviors like aggression and kind of being resistant to care. There's very practical things on there that can be helpful, and I'll put that website in the chat for you. You know, I'm also thinking about the fact that she's still been there a relatively short period of time since December. And I feel like, you know, it's a good sign that, you know, exactly as what we would expect when the husband came in and kind of helped a little bit more with that caregiving so that she can sort of trust them more and kind of like decrease the stress, like that sort of decreasing that stress of the transition sounds great. And again, like we're now at the 6-month part. Now we're hoping that she's doing so, maybe doing better. It's just like everybody sort of settling into that routine. You know, I do think, you know, it's great that the husband is getting that support. You know, there are FTD specific support resources that many people have found helpful. So for other family members to connect that, there's a couple based in Washington and Eastern Washington. There's the one through Richland, and then there's 2 in the Seattle area. But I believe at least one of the Seattle ones is still virtual, so they could attend anywhere. And again, the Association for FTD is just a great website. You know, and sort of talking about those things like that, you know, importance of, you know, avoiding overstimulation, you know, helping, you know, recognizing that, you know, with FTD, you know, that sort of distraction and redirection isn't as helpful for them as folks with Alzheimer's. And so sort of finding those like activities that she can do in to sort of help her with that sort of routine and engagement is something that is often helpful for folks with FTD. Those were my initial thoughts. Sure.
Thank you.
Thanks, Karen. And Trang, you have your hand? Yeah.
Yes. Patrice had a question about I am Haldol. If it's, you know, how you feel about I am Haldol. I would say that typical antipsychotics is usually not recommended. We have a few neurologists here, and correct me if I'm wrong. From what I read, first-line agent for FTD is an SSRI or trazodone, correct? So that's why I asked earlier if the patient has insomnia issue, then trazodone could help with insomnia and FTD if it's a true diagnosis. So it sounds like Zydus is helping the patient, then I think there's no need for IM. And then what I also read is that if there are cases that we're not sure if it's actually Alzheimer or FTD, then it's appropriate to try or antipsychotic. It sounds like Zydus is helping the patient, and she's now. So, I don't know. What do you think about that? We have a few neurologists here. So that's that. Yeah, I wanted to kind of answer the question of I am Haldol.
Yeah, thank you, Trang.
Oh, I'm sorry. I just wanted to add, the facility kept asking me about I am Haldol. I'm like, no. That it seems like, you know, just to make the patient quiet, it doesn't seem appropriate. But that they were asking me for it initially.
And it sounds like she's doing so much better with the Zydus, thankfully. In terms of medications, and I agree with Dr. Russo that the diagnosis, I think, is not clear at this juncture. That said, people who have FTD can become more agitated when you start a cholinesterase inhibitor. So in your history, it looked as though she was doing better on the rivastigmine. Who knows? But people I don't know. But people with FTD, if they are having problems with disinhibition, behavioral discontrol, agitation, the cholinesterase inhibitors, such as rivastigmine or donepezil or galantamine, can cause worsening behaviors and typically are avoided. Kimmy, do you want to add anything?
I agree. Of course, we always, if somebody has an improvement on a cholinesterase inhibitor, we start thinking about Lewy body disease, which of course then you would really want to avoid IM Haldol. Yeah, there's no, all medications to help with behavioral issues in FTD is all off-label use at the moment, but absolutely reaching for SSRIs to kind of just reduce the sort of intensity and frequency of some of these compulsive behaviors, which can be potentially harmful to the self or others.
Thank you.
Great. We have a couple of moments. Does anybody have a last comment or question before we shift to the last slide? If so, unmute yourself and speak or pop it in the chat.
Yeah, I just want to say, Patrice, this patient is so lucky to have you, to have the level of excellent care that you're providing to her is something that many patients don't have. And so you should feel really good about the work that you're doing.
Oh, thank you so much. I'm grateful to be able to help, and I know that this is what Ripple Care is about, is trying to help seniors in need. It's rewarding, to say the least, but just to hear the smile on the husband's face, and I saw the patient yesterday and she's just thriving, so I'm stoked. But now I've gotten so much more information on how to really look at a patient and really deep dive through the information that's given to make sure how to move forward. So that was my question. Moving forward, if things start to change, is there any non-pharmacological or pharmacological ways of helping to manage her? She's on just 5 milligrams right now of Dezitis, so that's my question.
Thank you, Patrice. Yeah, great case. And Mimi, one last.
Yes, thanks. And thank you, Patrice. And I would like to echo what Barack had to say. I don't have the answer to your question about kind of what next, but this is a case I would love to hear an update in about 6 or 9 months. We should keep track of those on a and invite people back. Thank you.
Yeah, thank you. And I love how, her gardening is something that is being supported in the community, and like seeing her a whole person and finding ways for her to get out in nature and in the dirt. And these are wonderful non-pharmacological enriching things so yeah, please do come back, and thank you again. And just briefly, next session, as I said, is Dr. Hilary Wang, who's going to talk about postoperative delirium, best practices for prevention and management. And please fill out your 1-minute end of session survey. Thank you.
Thank you.